Hello everyone and welcome back. I'm Joe Chappelle and you're listening to episode 56 of the OBGYN podcast. As promised, I have a ton of new material coming out for you in the next few weeks, in addition to some more interviews from the National Perinatal Association annual meeting that just happened in April. As a reminder before I get started today, all the transcripts are now going up on the website www.obgyn.fm, so you can go find them there. Now, these transcripts, the show, the website, are all supported by the people who support us on Patreon. So if you like the show and you want to support it, please, you can go find that link on the website as well. Now, on to today's episode. One of the rising trends that we see in obstetrics is the elective primary cesarean. What I've always found difficult is articulating the risks and benefits so that these women who are requesting it are well informed before they make that decision. So I was really happy when Dr. Bergoy told me he wanted to tackle this topic. I always know that when Oystein sends me an episode that it's going to be extremely well researched and comprehensive, and he did not disappoint. This is really a grand rounds level discussion, and he walks us through every important study on the subject. So, grab some coffee, strap yourself in, and let's get started with episode 56, Elective Cesarean Delivery.
Hello and welcome to the OBGYN podcast. My name is Oystein Bergoy and I'm an OBGYN resident working in Norway. Today I would like to talk to you about complications following cesarean section. As most of you probably know, cesarean section is one of the world's most commonly performed operations. It is a procedure we should know all the ins and outs of, both in order to do the procedure ourselves and to inform our patients about it. Before we get deep into the numbers and studies, I think I should give you some information to keep in mind as we go along. In order not to make this too overwhelming, I have had to narrow the focus on which patients to address. My main goal is to prepare us for the counseling of the patient asking for a cesarean section on so-called maternal request, i.e. with no clear medical indication for the cesarean section. The reason for this is that where a cesarean is medically indicated, it's usually easier to counsel the patient about the more clear risks and benefits about having the cesarean or not. Therefore, I have tried to find studies looking at exactly this patient group, but sometimes I've had to look for more or less suitable proxies. I will address both the long-term and short-term harms and benefits for both the mother and the child. Even though you might find the scope of this podcast narrow, you will be able to use a lot of the information to counsel other patients as well, especially with regards to long-term complications. Unfortunately, as in most of our science, the majority of the studies I found are done in high-income countries with all that entails of antenatal, perinatal and postnatal care, socioeconomic factors, diet, family planning, comorbidities, facilities and so on. Please keep this in mind when you try to think if the studies presented can be used to inform your own patients. One of the most important tasks when reading a paper is, in my opinion, to evaluate whether the population studied is reflective of one's own patient population. If not, it's not certain you can use the findings of the paper in question. I also want you to know that our knowledge of complications following a cesarean section often stands on very shaky ground. For instance, as you have most definitely noticed, if you practice obstetrics, there are many ways of doing a cesarean section and many ways of managing a vaginal birth. Examples of factors that may vary greatly between studies, but are rarely described in the paper, may be the degree of sharp versus blunt approaches during the cesarean section, the ratio of forceps versus vacuum use in operative vaginal delivery, prophylactic antibiotic use, analgesic use, the expectation of the patient of what a normal birth is, and what indication local guidelines say there are for emergency cesarean sections versus vaginal operative deliveries versus expectant management. Furthermore, many studies do not have an intention to treat protocol. This means that they have looked at complications based on the actual route of delivery. And why is that a problem? It is a problem because the opposite of an elective cesarean section is not a vaginal birth. It's a trial of labor. If you want to know if trying a vaginal delivery is safe compared to an elective cesarean section in a particular patient, you have to know the outcomes of exactly those two scenarios. Namely, what are the risks of an elective cesarean section versus a trial of labor that might end up with a vaginal delivery or an emergency cesarean section. If you look at the risks based on the route of delivery, you will not get your question answered, and therefore you can't use this info to inform your patient properly. I've tried to address these problems with finding studies that have an intention to treat protocol or letting you know when they don't. I've also tried to find research with clearly defined patient populations and have found 2 population groups where there are a certain amount of data. These are patients who have not had a previous cesarean and has no medical indications for one, and a patient who has had one single previous cesarean section. In addition, to address some serious but rare complications like maternal mortality and abnormal placentation, I will have to use studies with aggregated data, not separating between different clinical scenarios or patient populations. One last thing before we start. Please know that this is not a systematic review. I've tried to search for studies as broadly as I can, following links and references and looking up topics in aggregated sites like uptodate.com. I think I've found the most important studies that keep getting referred to, but I can never be sure. If you have some studies or other content you missed, I'd be grateful if you shared it with us on our Slack group. With that long introduction out of the way, I'll start with talking about short-term complications. First, I'll briefly go through the rare but serious outcomes. Most serious of them all is probably maternal and neonatal death. It's hard to exclude all confounding factors and find out exactly what deaths are attributable to cesarean section itself. A study in AJOG from 2014 estimated that 2 to 6 women die each year in the United States because of cesarean section alone. This translates into 0.2 to 0.6 per 100,000 cesarean deliveries. Reasons might be complications to anesthesia, postoperative infection, amniotic fluid embolism, or thromboembolism. When it comes to neonatal death, it was hard to find any good data on the risks of cesarean section itself. In the up-to-date article called Cesarean Delivery on Maternal Request, 2 studies are mentioned that have found a probable slight increase in neonatal mortality after an elective cesarean section compared to a vaginal birth. But both studies were limited by a significant risk of confounding factors, meaning that the risk observed might be due to the indication of the cesarean section and not the operation itself. These mortality rates were mostly based on the risks of cesarean section in general. Now I'd like to tell you about short-term risks of a planned cesarean section versus a trial of labor in the 2 patient populations outlined in the start, namely those without a prior cesarean section and those with one previous cesarean section. First, let's have a look at a planned cesarean section versus trial of labor in women with no prior cesareans, who are at term in a normal pregnancy. This is, for example, the patient with a non-pathological fear of labor but no other medical indications for a cesarean. How should we counsel her about the risks and benefits of her options for delivery? Cochrane unfortunately can't help us with this question, since they in 2012 tried to make a meta-analysis of RCTs but unsurprisingly found none. Visco et al. Made a systematic review article in 2006 published in the Green Journal where they tried to investigate this topic. They found very few studies that reported what kind of delivery was planned, but rather just reported the actual route of delivery. Therefore, they were unable to draw firm conclusions. Of what the authors called moderate quality evidence, they found a decreased risk of postpartum hemorrhage in planned cesarean section versus planned vaginal delivery, but a prolonged hospitalization of the mother when a cesarean section was performed. No numbers are stated in the article, so it's unclear how large these risks are. The review states that it sought to compare delivery methods based on the mother's preference, but it was a bit hard to find what kind of pregnancies were included and excluded. It was also a bit unclear to me how the studies were measured with regards to quality and which endpoints were studied through RCTs and which had only observational studies as a foundation. I was able to find 4 additional studies not included in the review article. These were all observational studies. The first was a study by de Klerk et al. Published in 2007 in the Green Journal. It was based on a database of birth certificates from Massachusetts between 1998 and 2003. It divided all low-risk nulliparous women into 2 groups, namely planned cesarean and planned vaginal births. This is therefore the only study with an intention to treat protocol I could find on this topic. The groups were defined on whether they were coded as in labor or not. Those who were coded as having a cesarean section but did not have a labor code was defined as a planned cesarean section. Those who had a code for having been in labor and had a code for either vaginal delivery or cesarean section was defined as a planned vaginal delivery. If you have ever worked in a labor ward, you know that a woman who has been scheduled for a cesarean section may present in labor before said cesarean section. So some of the women laboring might be planned cesarean section who either decided to deliver vaginally or have an emergency cesarean section. If this has any effect, you'd suspect it to affect the planned cesarean group positively, as they get rid of their potentially more complicated emergency cesarean sections. The main outcome studied was rehospitalization, and they found a near double risk for this in the planned cesarean section group. The absolute risk was 2% versus 0.75% in the planned vaginal group. Mainly this was due to wound infection. The next study was by Allen et al., published in the Green Journal as well. This is a retrospective cohort study from 2006 based on a database containing all pregnancies in Nova Scotia, Canada from 1988 to 2002. I will try to go a bit deep into the study as it's maybe the most important one addressing our question about first-time cesarean section on maternal request. This is because it looked for several important complications and at the same time tried to divide its participants into groups based on planned mode of delivery. I don't think they quite succeeded, but I'll get back to that. 5,779 nulliparous women with low-risk pregnancies were enrolled. Of those, 879 women had a cesarean section without labor and was compared to the rest who were induced around term. All cesareans had a medical indication, whereof 85% were breech or other malpresentations, and around 5% were because of suspected cephalopelvic disproportions. Of note, 5% were because of fetal distress, and you would expect many of these cesareans to have been performed fairly acute. So it's hard to know whether these were really planned vaginal or planned cesarean sections. Furthermore, only around 85% of the women undergoing cesarean section had regional analgesia. If this also accounts for the anesthesia, that means that 15% approximately were done under general anesthesia, which sounds very high and unnecessarily risky. There were no breech presentations in the induction group, whose main indications were post-mature pregnancy, 56%, and pre-labor rupture of membranes, 27%, making up together 83% of all inductions. Being an observational study, the authors tried to reduce the risks of confounding by controlling for maternal age, type of anesthesia, use of antibiotics, gestational age at delivery, and birth weight. The main findings were that elective cesareans reduced the incidence of early postpartum hemorrhage with an NNT of 32, and a composite outcome of maternal mortality with an NNT of 34. PPH was defined as bleeding estimated to over 500 milliliters after vaginal delivery and over 1,000 milliliters after a cesarean. A composite outcome is kind of like a bag you put different outcomes in. If a participant obtains one or more of the composite outcomes, they are counted as having obtained the composite outcome. It's often used to study rare events. A problem arises if one of the composite outcomes occurs a lot more frequent than the others, as it makes up the bulk of the composite outcome. This might be a problem because it looks like a rare or serious event is more common than it is because it in a way free rides on the back of the more common event. In other words, the difference in composite outcome between the groups in this study may be driven entirely by the difference in PPH. This is namely a part of the composite outcome. Also note that the way PPH is defined, the participant in the planned vaginal group could in theory have bled less than the ones in the cesarean section group, since we don't know the average bleeding estimates. There were no differences observed in transfusion rates between the groups. No significant differences were seen either in the rates of thromboembolism, wound infection, febrile morbidity, intraoperative trauma, hysterectomy, or maternal death. The women who had the cesarean section had on average 1 day longer hospital stay than the others who were induced. A large Chinese retrospective cohort study of nulliparous women published in AJOG in 2015 used special consent forms to identify women who had been scheduled for an elective cesarean on maternal request. They compared these groups to a group of planned vaginal delivery. This group was defined as not being scheduled for an antepartum cesarean. All were singleton and vertex and fairly similar in baseline characteristics, and when not, it seemed to favor the planned vaginal group. In the planned vaginal delivery group, almost 81% achieved a spontaneous vaginal delivery, and around 7% had an assisted vaginal delivery, and around 12% ended up with an intrapartum cesarean. The study did not specify its primary or secondary outcomes. They found no significant differences in maternal death, severe postpartum hemorrhage, maternal ICU admission, maternal infection, thromboembolic events, maternal organ injury, perinatal death, or necrotizing enterocolitis. The definition of severe PPH in the study was if there were 4 grams per deciliter fall in hemoglobin, the patient received a blood transfusion, or if she needed an intervention like a Becker balloon. The study found a decreased risk of mild postpartum bleeding favoring the planned cesarean section group, 1.7% versus 3.4%. This was defined as a bleeding in excess of 500 milliliters, but not meeting the criteria for severe PPH. Maternal organ injury were injuries involving the anal sphincter, the uterus, or intraperitoneal organs. Where they did find a difference was in the neonatal morbidity, where planned cesarean delivery on maternal request was better than planned vaginal delivery when it came to birth traumas for the baby, 0.2 per mil versus 1.1 per mil. Less frequent admissions to the NICU, 3.0% versus 3.7%. Fewer neonatal infections, 0.4 versus 0.7%. Fewer cases of hypoxic ischemic encephalopathy, 0.4 versus 1.9 per mil, and fewer cases of meconium aspiration syndrome, 0.2 per mil versus 0.6 per mil. The only factor that was increased in the planned cesarean section group was RDS with 0.6% versus 0.4%. There were quite a few elective cesareans performed between 37 and 39 weeks of gestation. The authors did a subgroup analysis based on week of delivery and found that the RDS risk was only significant in the group under 39 weeks gestation. They explained that it was not uncommon in their hospital to grant elective cesareans a bit early to accommodate parents' wishes regarding, for instance, specific birthday dates. The authors comment that this study is limited by it only being able to record short-term outcomes. They did not record outcomes after the initial discharge. Hence, complications might have been underestimated, especially in the planned vaginal delivery group, since they stayed approximately 1.5 days, shorter than the around 5.5 days the planned cesarean patients did. They also question how generalizable this study is to countries with a different population. Especially the BMI rate seems to be a challenging factor to ignore, since the highest incidence of obesity was seen in the elective cesarean group with 3.6%. This might skew the results in a more favorable way for the cesarean group than one would expect in a country with a higher obesity rate. Some additional limitations, in my opinion, was that the induction rate was 31%, which some might find a bit high. The authors did, however, control for medical complications in the pregnancy. It is unclear for me if the elective cesareans before week 39 were treated with antenatal corticosteroids or not. If not, this might offset some of the difference in the RDS rates. Lastly, some of the outcomes seem to me to be exceptionally low. For instance, the incidence of 3rd and 4th degree perinatal tears were in total around 0.45%. In Norway, where I practice, this number is at least double, if not 3 times that at a normal labor ward. Moving on to the last study looking at Primit Gravida, a Canadian observational study from 2017 looked at a national registry that included all in-hospital births in most of the country's provinces from 1991 to 2005. The authors used the database to compare around 2.2 million planned vaginal births with around 46,000 elective cesarean deliveries for breech presentation. They used the latter as a surrogate for a cesarean on maternal request, and looked at differences in maternal mortality and severe morbidity. The women were at term, singleton, and had no previous cesarean sections and none of the comorbidities that the authors had deemed as not low risk. In the breech group, they also tried to exclude the ones that had an emergency cesarean. The planned vaginal group also included breech deliveries. They found that there was a small but significant increase in overall severe morbidity in the cesarean group versus the planned vaginal delivery group, 2.73% versus 0.9%. Most of these were due to wound infection, but also major morbidities like cardiac arrest, hysterectomy, and venous thromboembolism were statistically significantly increased in the cesarean group. Although these risks were relatively small, the absolute risk increase for cardiac arrest was, for instance, 1.6 per 1,000 deliveries. Keep in mind that these are healthy young patients and that the planned cesarean is common. Hemorrhage requiring blood transfusion was increased in the planned vaginal group. The authors speculate that the reason why blood transfusions were more common in the planned vaginal group, but hysterectomy was more common in the planned cesarean group, was due to the ease of hysterectomy when already doing a cesarean. There was no significant difference in the mortality between the groups, but it's unclear whether the study was large enough to detect a potential difference. Some limitations with this study that might have influenced the result were that there were some parameters one would have liked to know that was not available. For instance, the BMI of the women that might predispose to wound infection and parity that might influence the risk of a planned vaginal delivery. Also, the study might have excluded patients in the vaginal group who had complications arising after the onset of labor, but were apparently healthy before they entered labor, and thus making the planned vaginal group look more favorable. Likewise, some patients may have ended up in the elective cesarean group when they in reality had an emergency cesarean for a complication not coded, but this lack of appropriate coding might also have affected the planned vaginal group. Also keep in mind that the planned vaginal group included the breech deliveries, which has an increased risk of emergency cesarean sections, but it's hard to say if these numbers were high enough to make an impact on the overall risks. So, when it comes to short-term complications after a planned cesarean section versus a trial of labor in women with normal term pregnancies and no prior cesareans, we can perhaps say that either method of delivery for the individual woman is safe in high-income countries. But on a population level, there seems to be an increased risk of severe maternal morbidity and a slightly lower risk of serious neonatal morbidity associated with an elective cesarean section compared to a trial of labor. After that slightly frustrating topic, it's time to have a look at a better studied clinical question. How does a planned repeat cesarean compare to a trial of labor after a cesarean? I will, by the way, hereafter use the abbreviation TOLAC for this group. You also see the abbreviation VBAC sometimes used interchangeably, but this is not accurate as a VBAC is short for vaginal birth after cesarean and should be used for a successful TOLAC. So when I use the term VBAC hereafter, it means that the study in question have looked at the actual route of delivery as opposed to the planned route of delivery. One of the main fears of the clinician caring for a woman doing TOLAC is the risk of rupture of her scar that might result in maternal circulatory compromise and fetal demise. On the other hand, a repeat cesarean can be challenging if there has formed adhesions that increases the risk of damage to the bladder or intestines when doing the operation. Also, the risk for placenta previa is increased with a prior cesarean. In order to counsel our patients properly, we need to know some numbers. I found a couple of studies, all observational, that might help us. There are no Cochrane analyses to guide us this time either. When they last did a review in 2013, the authors found only one useful RCT, but it had only 22 participants. On a side note, it's interesting though that they had been able to randomize these patients to do a TOLAC or repeat cesarean. The first study I want to mention is a meta-analysis by Gies et al. Published in the Green Journal in 2010. The population was women from high-income countries with singleton cephalic pregnancies and one prior cesarean. They excluded pregnancies younger than 37 weeks and where there were known fetal anomalies. A major limitation with this paper is that all the studies included reported mode of actual delivery and was therefore not intention to treat. However, looking at a few random studies included, they seem to have differentiated between elective and emergency cesareans, making it less likely that a failed TOLAC is grouped together with elective cesareans, at least in some of the studies. The main findings were that compared to VBAC, an elective repeat cesarean had a slightly increased maternal mortality from 0.04 per mil to 0.13 per mil, with an number needed to harm of approximately 11,111. Uterine rupture was unsurprisingly decreased from 4.7 per mil to 0.26 per mil, with an NNT of approximately 227. Perinatal and neonatal mortality was also slightly decreased from a bit over 1 per mil to around half a per mil, with an NNT of approximately 1,250 and 2,000 respectively. In 2012, Crowther and colleagues published a study in the open access journal PLOS Medicine, where they let eligible women choose between a TOLAC or a second cesarean. These were Australian women with singleton pregnancies, 37 weeks or more in cephalic presentation, and no contraindications to vaginal births based on a pre-specified list. This was the only prospective observational study with an intention to treat protocol that I was able to find on the topic at the time of doing my research. And I guess this is as high quality evidence we will have from a single study so far. This was the only prospective observational study with an intention to treat protocol that I was able to find on the topic at the time of doing my research, and I guess this is as high quality evidence we will have from a single study so far. This study also included a nested randomized trial, and this is where the 22 participants in the Cochrane analysis mentioned earlier comes from. The study participants split into two groups as follows. 1,225 chose a TOLAC, and 1,098 chose an elective cesarean. The groups were fairly similar with regards to baseline characteristics, although the cesarean section group had higher BMI and higher socioeconomic status. Parameters like gestational age, smoking, maternal age, and previous successful vaginal births were similar. The latter were 13% and 15% respectively. Of those who opted for TOLAC, around 43% achieved a vaginal birth, and the rest ended up with a cesarean section. Of these, around half were elective, and around half were as an emergency procedure. I would advise you to check if these proportions are similar in your institution before considering applying the findings of this study into your practice. In the other group, almost 98% delivered by cesarean, and the vast majority, around 88%, did this through a planned procedure. The primary outcome was a composite outcome of perinatal death and serious neonatal morbidity. I want to go a bit into the details here, since this study is important and the interpretation of composite outcomes can be a bit difficult. As you remember we talked about a bit earlier, a composite outcome is a grouping together of different outcomes into a single outcome. If one participant obtains one or more of the outcomes, this is recorded as one composite outcome. One main benefit of using this type of outcome is to be able to study rare outcomes without having to make your study size too large. This easing comes, however, with a price. Several studies and articles have pointed out some major limitations of using composite outcomes, and these are mainly that the individual composite outcomes are often not very well crafted. If, for instance, the outcomes are not similar in severity and frequency, a single outcome within the composite outcome can alone make the composite outcome significantly different between the two groups. Thus, the reader might be led to think that the intervention leads to a difference in outcomes, which it really does not. I know this might be a bit challenging to understand if you have not thought about it before, but I will try to use the Crowther study as an example. I've linked to some of the articles concerning composite outcomes in the show notes if you want to nerd out on the topic. As I said, the Crowther study had a composite outcome as its primary outcome called death or serious infant outcome. This was significantly reduced in the elective cesarean group compared to the TOLAC group, 0.9% versus 2.4%, from which the authors calculated an NNT of 66. You might get the impression that if we did cesarean section on all of these women, you would save a few lives. But here is an example of where a composite outcome can be very misleading. In a table, the authors list the individual outcomes included in composite outcome. Death was recorded 0 times in the cesarean section group and twice in the TOLAC group, of course not reaching statistical significance. The authors also write that the cause of the 2 deaths remained unexplained after autopsy. No individual outcomes reached statistically significance in of itself, but the outcome that came closest was the cord blood deficit equal to or more than 12 that had a p-value of 0.06. You can hardly argue that death and base deficit of 12 are equally severe. Of the secondary outcomes, a bleeding of 1500 milliliters or more or requiring transfusion was the only outcome reaching statistically significance and was reduced for the patients who got an elective cesarean section, 0.8% versus 2.3% with an NNT of 66. For me, it's hard to know what to take away from this study other than that in high-income countries, in the short run, both TOLAC and a repeat cesarean section seems fairly equally safe. This is when not considering potential future pregnancies. Various respiratory diseases are perhaps the most serious short-term complications of a cesarean section for the child. These run the spectrum from transient tachypnea of the newborn, TTN, and respiratory distress syndrome, RDS, to persistent pulmonary hypertension, PPHN. It is hypothesized that labor and rupture of membranes triggers a catecholamine surge in the fetus, which in turn reduces fetal lung liquid and increases the secretion of lung surfactant. A large Danish prospective cohort study published in 2008 in BMJ found an increased risk of respiratory morbidity defined as TTN, RDS, and PPHN in children delivered by elective cesareans compared to those born after trial of labor, regardless of the final route. All live-born singleton births between week 37 to 41 without congenital malformations in one of Denmark's largest tertiary hospitals were included between 1998 and 2006. The authors then compared children born by elective cesareans to those born after trial of labor, including by emergency cesareans. The comparisons were done in 2 main ways. First, the elective cesareans were compared to the trials of labor in each gestational week. Second, the elective cesareans in each week were compared to a trial of labor in week 40. The latter was done to compare elective cesareans to what the authors meant was the most realistic alternatives in most normal pregnancies, namely a spontaneous delivery at term. They also controlled for various potential confounding factors, both for the mother and child, and did a subgroup analysis of pregnancies deemed as low risk, i.e. those with intrauterine growth restriction, diabetes, preeclampsia, or hypertension. The primary outcome was a composite outcome that the authors called respiratory morbidity and consisted of TTN, RDS, and PPHN. I think this was a reasonable and meaningful use of composite outcomes, since these diseases are not always easily separated and have similar treatment algorithms. The main result from the study was that compared to babies born after a trial of labor, the babies born after an elective cesarean was more likely to suffer from respiratory morbidity. When compared to those who underwent a trial of labor in the same week as the elective cesarean was done, there was a significant difference in week 37, odds ratio of 3.9, week 38, odds ratio of 3.0, and week 39, odds ratio of 1.9, but no significant difference in week 40 or 41. After analyzing the subgroup defined as low risk, they found an augmentation of the risks, but there was still no significant difference in week 40 and 41. When compared to a trial of labor in week 40, there were only a significant difference in the risk for those delivered by elective cesarean in week 37 and 38. Odds ratio 7 and 3.5 respectively after controlling for confounding factors. There were no significant difference in elective cesareans from week 39 and older, but the 95% confidence interval was fairly wide, so further studies might change this. The authors also had an outcome that they defined as serious respiratory morbidity. This was also a composite outcome of the neonates requiring treatment with 3 or more days with continuous oxygen supplementation, nasal continuous positive airway pressure or a period of mechanical ventilation. There was a significant increased risk of this outcome in the babies born after an elective cesarean section in week 37 and 38, both compared to a trial of labor in the same week and in week 40. No significant difference was observed in babies born in week 39 and older, but again, the confidence interval were large enough that larger studies might change this. I think the take-home message from this study is that elective cesareans are a potential risk factor for acute respiratory illness, but that this is mostly mitigated by not performing an elective cesarean before week 39. This is, at least in Norway, standard practice. According to UpToDate.com, the incidence of RDS in an American population in week 39 is approximately 0.3%. That is also reflected in the large confidence interval in this study when approaching week 39 and older gestations. The number of trials of labor one would have to do to avoid one RDS after an elective cesarean is likely to be high. That being said, as we keep coming back to, if we increase elective cesareans on maternal demand, we will probably see more acute respiratory pathology on a population level. To sum up short-term risks of a repeat cesarean versus a TOLAC, these options also seem to be fairly equally safe for the expecting mother when assessing the risk of the individual patient. On a population level, there is a small increase in uterine ruptures when performing TOLACs, but based on these studies mentioned, this does not seem to increase maternal mortality. We have not addressed risk factors or challenges that will make outcomes like uterine rupture more likely, like a prior non-low transverse incision or a labor ward unfamiliar with TOLAC. The latter might also make it more dangerous for a woman to suffer a uterine rupture once it has occurred compared to a ward that is trained on that scenario. These are examples of factors that needs to be considered when counseling your patient with a prior cesarean and planning her birth. With regards to the risk of the child, as long as the cesarean is performed in week 39 or later, it does not seem to be a big difference in performing a repeat cesarean versus a TOLAC. We have so far explored the short-term consequences of a cesarean section for mother and child. I would now like to shift the focus to long-term complications. I found 2 systematic reviews and meta-analysis I would like to tell you about. These studies do not look strictly at cesareans on maternal request, so keep that in mind. They include quite different studies, since one looked at repeat cesareans compared with VBAC and included retrospective studies, whereas the other included only prospective studies and looked at cesareans versus vaginal deliveries in general. The one that explored VBACs was from 2011 and is much cited. It's by Marshall et al. And was published in AJOG in 2011. This was a meta-analysis of observational studies looking at complications related to increasing numbers of cesareans. All of the studies included had cephalic singleton pregnancies from high-income countries with at least one previous cesarean, and exclude studies looking at specific diseases and conditions, and studies conducted before 1980. In total, 2,280,000 births were included in the meta-analysis. It found that both placenta previa and a placenta accreta increases with increasing amount of cesarean sections. With regards to placenta previa, the study reports 1% in women with 1 previous cesarean and 2.8% in women with 3 or more. To repeat something I said before, remember that even though the absolute numbers may seem low to you, a low percentage may translate into a high number of patients if the prevalence is high enough. In other words, if multiple cesareans becomes more prevalent in a population, the number of abnormal placentations might reach a number we would be uneasy with as a result. The study also found that women with a placenta previa and 3 or more prior cesareans, compared to women with a previa who had no prior cesareans, had a significantly increased risk of placenta accreta, 50 to 67% versus 3.3 to 4%, and hysterectomy, 50 to 67% versus 0.7 to 4%. A composite outcome of serious maternal morbidity was also increased to 83% versus 15%. I won't go into the details of this outcome, but it contained mostly hard endpoints and few or no surrogate endpoints. The last paper I will talk about is by Keeg et al. They published a comprehensive systematic review and meta-analysis that looked at long-term risks and benefits of cesarean sections for the mother, child, and subsequent pregnancies in PLOS Medicine in January 2018. They included studies that compared vaginal deliveries with cesarean sections at term, not necessarily regarding the indication for these, nor the rate of operative vaginal deliveries. Most were large prospective cohort studies, but it also included one RCT. This was the, for many of you, well-known study called the Term Breech Trial, which randomized women with a breech pregnancy to either undergo a trial of labor or a cesarean section. The result from the RCT was reported independently of the observational studies for statistical reasons, and I will do the same. For outcomes related to the mother, they included 23 prospective cohort trials and the one RCT that gave a total of almost 3,850,000 participants. In the main article, the risks are given in odds ratios, since this is the correct way of reporting findings from these types of observational studies. However, the authors have calculated numbers needed to benefit or harm, also called NNB and NNH, and supplied these in a table that you could check out. The link is in the show notes to the article. I will use the numbers needed to benefit and harm instead of the odds ratios wherever I can, since I find odds ratios often hard to interpret and therefore of little help to me when I counsel my patients. However, there's a big caveat with these numbers that it's a little nerdy, but still very important. Number needed to treat is dependent on the time to follow up. This means you can't really use it with a lot of confidence when there's a large difference in the time the patients are followed up for, and the studies have not made a statistical adjustment for this. In the studies included in this review, there are often a vast difference in follow-up time. Take urinary incontinence, for example. The studies included followed the patients for everything from a year or two and up to 20 years after giving birth. Even though the studies all report an increased risk of urinary incontinence after vaginal delivery compared to cesarean section, it does not make much sense to talk about number needed to treat when the follow-up time is so variable. If we did use the numbers the authors have calculated, namely 17, we still have to answer what this number really means. Does it mean that you have to do 17 cesarean sections in order to spare one woman for urinary incontinence for the first 5 years postpartum, or 20 years, or her lifetime? As much as I'd love to, I can't go into the weeds of this any further. I have provided a link to an article elaborating on this in the show notes. Sufficient to say, you cannot calculate NNT if you have varying and long follow-up times unless you have done some statistical magic called a Kaplan-Meier analysis. This is, as far as I can see, not done here, and I will therefore only quote NNTs when the outcomes are not that far into the future, like future pregnancies. I have to admit that I'm a bit on deep water here, so please do not hesitate to let me know if you are better than me in statistics and are tearing your hair out because of my use of these concepts. Okay, so back to the paper. The authors grouped their outcomes into 3 categories, as I mentioned earlier: long-term outcomes for the mother, long-term outcomes for the child, and outcomes in any subsequent pregnancy. I will start with the latter. All of these findings were supported by the observational studies and not the RCT. As with the meta-analysis by Marshall et al. We just discussed, this paper by Keik et al. Has also explored abnormal placentation. Compared with no previous cesarean, having had one previous elective cesarean section increases the risk for in a future pregnancy of placenta previa with an NNH of 494. There was an increased risk of stillbirth with an NNH of 1,144. Women who delivered by cesarean were more likely to experience inability to become pregnant again compared to those who delivered vaginally with an odds ratio of 1.6. They also found an increased risk of placental abruption with an NNH of 534. With regards to uterine rupture and postpartum hemorrhage, I would refer you to the discussion we had under short-term risks. The risks for rupture and PPH quoted in this review is not, as far as I can see, adjusted for mode of delivery in the subsequent pregnancy. They may therefore quote the risk for VBACs and second cesareans as one number. Of non-pregnancy related maternal outcomes, they looked primarily at pelvic organ prolapse, urinary and fecal incontinence. This is a bit of a hot topic, especially if you get the urogynecologist into the discussion, and should probably be a topic of a podcast in itself. Annoyingly, the authors don't tell us much about the participants included, so we don't really know whether the women in the cesarean group only had deliveries by cesarean or if they might have had a VBAC in the follow-up time. They don't tell us whether they adjusted for this either. However, I looked at the studies included that reported a result on pelvic floor dysfunction. They all seem to have included women who only delivered by cesarean or vaginally, or they have had a follow-up time of maximum 18 months postpartum. The rate of operative vaginal delivery, which is probably a risk factor of these outcomes as well, are not mentioned either, but authors write that they included these patients in the vaginal delivery group if they found them in the studies included. The numbers from observational studies found that when compared to vaginal delivery, women who delivered by cesarean section were more protected against pelvic organ prolapse with an OR of 0.9 and a confidence interval, and a 95% confidence interval of 0.17 to 0.51. And with urinary incontinence, there was an OR of 0.56 with a 95% confidence interval of 0.47 to 0.66. No difference were seen with regards to fecal incontinence. The RCT, who had a 2-year follow-up, was not able to show any difference between the groups with regards to urinary or fecal incontinence. The observational studies had, as previously mentioned, varying follow-up time from 12 months to up to 80 years of age. The studies looking for pelvic organ prolapse had 20 years follow-up or longer. It is important to note that all of these outcomes did occur in the cesarean delivery group as well, including fecal incontinence. So a cesarean section, counter probably to many patients' beliefs, is not able to fully protect against these forms of pelvic floor dysfunction. Of secondary outcomes, the observational studies found an increased risk of dyspareunia in those who were delivered by cesarean section with an OR of 1.49, but this was not shown in the RCT. No differences were found with regards to pelvic pain, but the 95% confidence interval just hit 1.00 and had a range from 0.54 to 1.00, almost favoring those delivered by cesarean. More studies looking at this might change this result. The RCT looked at painful or heavy menstruations following the delivery but found no differences. Regarding the long-term complications of a cesarean section for the child, studies have found an association between cesarean section and asthma, allergy, and obesity in childhood. The Keeg paper chose childhood asthma up to age 12 as their primary outcome for the child. They found an increased risk of asthma in the children delivered by elective cesarean versus after a trial of labor with an OR of 1.21, 95% confidence interval 1.11 to 1.32. The studies included here also varied in follow-up time and in primary outcomes measured. In the secondary outcomes in the meta-analysis, the authors also found an increased risk of overweight and obesity in the children born after an elective cesarean, but no significant difference in allergy and a decreased risk of inflammatory bowel disease. To summarize the findings on long-term complications of cesarean sections, there are some benefits and some harms. These are greater in absolute numbers than the short-term complications, and therefore long-term complications should probably be the topic we spend most time on in our average counseling. The ones you could argue are the most serious are mostly rare, although different patients will of course have not all the same definitions of what the most serious outcome for them personally are. It is also important to try to differentiate between risks only relevant for a subsequent pregnancy and the ones that also can affect the woman in front of you even though she will get a sterilization after this pregnancy. A cesarean section compared to a trial of labor seemed to protect against pelvic organ prolapse and urinary incontinence, and might also protect against inflammatory bowel disease for the child. However, it seems to increase the risk of future ability to conceive, stillbirth, abnormal placentations, dyspareunia for the mother, and for asthma and obesity for the child. A repeat cesarean compared to a VBAC is also associated with an increased risk of abnormal placentations, and this risk increases with the number of cesareans a woman undergoes. We have not found evidence that shows a cesarean section protects against fecal incontinence, nor have we found solid evidence of it protecting against pelvic pain, but this might change with larger studies. I've not discussed any pathophysiological mechanisms so far, and I won't say much about it now either. All I do want to say is that when it comes to the long-term outcomes for the child, there's a lot of fascinating ongoing research exploring the differences in the child's gut microbiome after a cesarean without prior labor compared to one born after a trial of labor. Especially our ongoing intervention studies exploring the harms and benefits of vaginal seeding followed with excitement. In these, the mother's vaginal bacterial flora is introduced to the newborn baby after an elective cesarean in order to try to give the child a normal gut microbiome. So, to try to summarize all that we have talked about, the goal of this podcast was to explore the risks and benefits of an elective cesarean done without any proper medical indication, as the cesarean section on maternal request is something all of us seeing pregnant patients should be able to counsel about. We wanted to know of both short-term and long-term effects for the mother and child. The studies we have looked at have been done in mostly high to middle-income countries, so keep that in mind when trying to use these findings in your practice. We have found that both options are equally safe with regards to short-term complications for the individual patient, but that they differ a bit more with regards to long-term complications both for the mother and child. On a population level, however, it would make sense to try to avoid unnecessary cesareans, since rare but serious complications will probably arise. Lastly, the risks for the mother is sometimes dependent on whether she wishes to have more children or not. I want to thank you for listening. I hope you have gotten some concrete advice to use when discussing the risks and benefits of cesareans with your patients.